بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will continue the lecture of the mandibular imaging and the temporomandibular joint. We have finished the anatomy and pathology of mandibular lesions, and now we are going to handle this small issue about the imaging of the temporomandibular joint. And you know that this joint is the articulation between the head of the mandible or the mandibular condyle and the temporal fossa, which is the depression in the temporal bone where the head of the mandible articulates with this part of the temporal bone. In between the head of the mandible and the temporal fossa, there is an articular disc which has a very characteristic anatomic structure and is a very important issue in the function of this joint. And first, we would like to see the very small anatomy of this area. And this yellow color represents the articular cartilage of the temporal eminence. And here is the articular cartilage covering the head of the mandible. And this is the joint capsule, which is presented here in gray color. And this is the very important structure, which is the articular disc. And this articular disc is formed of three parts: the anterior band, then the posterior band, and the intermediate zone. The disc is attached anteriorly and posteriorly to the joint capsule, and also the lateral pterygoid muscle, which has two bellies, the superior belly and the inferior belly. The superior belly is that which has an intimate relation to the articular disc and is involved in the movement of this disc as well. And posteriorly, there is a zone which is known as the bilaminar zone or the retrodiscal zone, which attaches the disc to the posterior joint capsule. Then the temporomandibular joint has three main components: the head of the mandible or the mandibular condyle, the articular fossa on the temporal bone, and the very important structure in between, which is the articular disc. In order to examine the temporomandibular joint by MRI, we should have a dedicated surface coil which enables to examine both temporomandibular joints in the same time. And actually, we should examine the joint during the or in the closed mouth position as well as in the open mouth position, and this applies for the left and the right joints as well. This is the appearance of the schematic appearance of the temporomandibular joint. This is the articular disc, and this is the anterior band, and this is the posterior band, and this is the intermediate zone. And here is the articular eminence of the temporal bone, and this is the articular fossa, and this is the mandibular condyle, the lateral pterygoid muscle, superior belly, and the inferior belly. And this is the joint capsule, and this band is the retrodiscal band. Then the disc, which is a biconcave structure, separates the joint into two compartments: a superior compartment and an inferior compartment. The superior compartment allows the anterior and posterior motion of the disc, anterior and posterior motion, while the inferior compartment of the joint allows the rotation of the mandibular condyle. And this an anterior and posterior motion, and this is rotational movement of the mandibular head. And the most suitable view by MRI to examine the temporomandibular joint is the sagittal oblique views, which are taken perpendicular to the uh, head of the mandible or to the joint line in the axial view. Then, yeah, in the normal situation, then you see the articular disc, which is this black structure, as a biconcave structure. This is the anterior band, and this is the intermediate zone, and this is the posterior band, and this is the retrodiscal or the bilaminar zone. Here is the mandibular condyle, and this is the mandibular fossa, and this is what we call the mandibular eminence. And in the closed mouth, the narrow part of the disc or the intermediate zone should be located between the head of the mandible and the articular eminence. And after opening the mouth, the disc will move anteriorly so that the narrow part of the disc or the intermediate zone will be also located between the head of the mandible and the articular eminence in normal conditions. And this is what I'm saying. This is the closed mouth view, and this is the articular disc. The narrow zone is located between the articular eminence and the head of the mandible. After opening the mouth, the mandibular condyle will move anteriorly, and the disc also will move anteriorly. Then you see the intermediate zone between the articular eminence and the head of the mandible. And sometimes you can see the disc which is dislocated anteriorly, like this one. You see this disc is in abnormal location. It is not located between the head of the mandible and the articular eminence, and that is what we call anterior displacement of the disc. And this is, of course, the tendon of the superior belly of the lateral pterygoid muscle. And sometimes this tendon is prominent, as you can see here, and it can be mistaken sometimes for the articular disc. And this is a sign which is known as the double disc sign. The double disc sign is the original disc and the tendon of the superior belly of the lateral pterygoid muscle, which may simulate the articular disc in sometimes. Then any abnormal arrangement within the temporomandibular joint, like diseases affecting the articular disc or affecting the joint itself. The TMJ is a joint similar to any other joints in the human body that can be involved in osteoarthritis, in rheumatoid arthritis, in many diseases. But frequently this joint is evaluated for abnormalities in the position and in the shape of the articular disc. And these abnormalities are collectively known as internal derangement of the temporomandibular joint. And the derangement may be secondary to abnormal disc morphology or abnormal position of the disc in relation to the mandibular condyle and the articular eminence. And these are some of the abnormal shapes that you can meet in the clinical practice. As I have mentioned, the disc is a fibrocartilaginous biconcave structure which will appear black in all pulse sequences. Then the disc may be rounded, may be flattened, may be perforated, may be crumpled, and all these abnormal shapes will result in abnormal position of the disc and abnormal motion during the closed and open mouth views. Then Some of other causes include chronic spasm of the lateral pterygoid muscle. This muscle is very important in the function of the temporomandibular joint. Trauma to the joint with fractures, osteoarthritis, and defects in the bilaminar zone. This zone, which is attached to the posterior part of the disc. It controls the anterior motion of the disc during the function of the joint. Then the dysfunction or derangement of the temporomandibular joint means that there is an abnormal relation between the disc and the articular surfaces, which are the head of the mandible and the articular eminence of the temporal bone. The clinical manifestations include pain, clicking, and movement restriction of the joint. And this disease is very, very common in females compared to males, and this is the range of incidence in both sexes. The disc, as I have mentioned, has a normal relation to the articular surface, and the narrow part of the disc, which is the intermediate zone, should be present between the articular, the head of the mandible and the articular eminence. And if you look to this sagittal MR of the temporomandibular joint, you can easily appreciate that this disc is slightly subluxated anteriorly. And this is the most common abnormality in this joint, which is abnormal anterior position of the articular disc. And anterior displacement is very common, and sometimes or many times it is asymptomatic. But there are other displacement of the disc which are considered rare, and many of the anterior displacement will produce symptoms. Then if the disc is anteriorly displaced or subluxated, and you say that this is the position of the disc in the closed mouth. After mouth opening, there may be recapture or reduction of the disc to its normal position, or recapture in one plane but not in the other, or may remain displaced, as I will show to you. Then this is a subluxated disc. And you look here, this is the temporomandibular joint, and this is the disc. The intermediate zone is anterior to the mandibular condyle. This means that this disc is slightly subluxated anteriorly. Then during opening the mouth, the disc has recaptured or regained its normal position. The narrow part of the disc, which is the intermediate zone, is in between the articular eminence and the mandibular head, which is the normal position. Then this is the same case, and you see the disc is slightly displaced anteriorly during the closed mouth position with recapture or re-achievement of its normal position during opening of the mouth. And this is also another example. The disc is displaced anteriorly. This is the articular disc, and this is the head of the mandible. Then the disc, most of the disc is anterior to the mandibular head. And after opening the mouth, the disc has recaptured its normal position with the narrow zone or the intermediate zone between the articular eminence and the mandibular head. But look at this case where the articular disc is displaced anteriorly, as you can see here. And after opening the mouth, the disc remains at its anterior position and is not achieving its normal rotation. Then here, this is anterior displacement with no recapture during the open mouth. And this is also another example. The articular disc is located anteriorly below the articular eminence, and after opening the mouth, you see that the articular disc is maintaining its abnormal anterior position. And see here, this is an MRI in the closed and open mouth views. And you see the articular disc is displaced anteriorly, and after mouth opening, which is limited, as you can see here, the opening mouth here is limited. The translation of the mandibular head is not free as we see in normal cases, then you see the disc is maintaining its abnormal anterior displacement. Then the abnormal orientation of the disc relative to the mandibular head and the articular eminence in both opening and closed mouth. Anterior displacement of the disc, as I have mentioned, is the most common finding, and the disc may reduce to its normal position during our open mouth, and sometimes the disc is not reduced during the open mouth, as you can see here. Posterior displacement of the disc when the posterior band exceeds the 1 o'clock position relative to the head of the mandible. And by the word stuck disc means that the disc is fixed to the temporal bone due to adhesion with no motion at all. And you see here, this is an anteriorly displaced disc. As you can see here, there is a good amount of joint effusion, and after opening the mouth, the disc is crumbled on and bended, as you can see here, with no recapture or no reduction to its normal position. And this is what we call the stuck disc, where the disc is fixed to the temporal bone. In the closed mouth, it is markedly anteriorly displaced. This is the tendon of the lateral pterygoid muscle. And after opening the mouth, the disc will maintain its position, being adherent to the temporal bone. This is what we call the stuck disc. Then indirect signs of internal derangement. The original sign is the abnormal disc position in relation to the mandibular condyle and the temporal eminence. And this position may change or may not change during opening the mouth. Also, if you see joint effusion, and this is one of the manifestations of internal derangement. If you see rupture of the disc of the retrodiscal layer or the posterior zone, which is attached to the posterior part of the disc, thickening of the lateral pterygoid muscle attachment, and of course, if you see evident osteoarthritic changes within the joint. And here you can see a significant amount of joint effusion as well as osteoarthritic changes with flattening of the mandibular head and some osteophytic lipping. And you may also have in the previous days, we used to have the conventional X-rays and the conventional tomography for the temporomandibular joint, but now we may have the help of the mandibular panorama, or also you can use the cone beam CT, or also use the original multi-detector CT with reconstructed images for the region of the temporomandibular joint. This is the normal joint where you can see the mandibular head and the temporal eminence with smooth articular surfaces and maintain the joint space. Of course, by the CT, you cannot identify thoroughly or properly the articular disc. And this is osteoarthritis. You see narrowing of the joint space, subarticular bone sclerosis, some osteophytic ribbing of the articular surfaces, which are the usual manifestations of osteoarthritis in any joint in the body. And this is an advanced osteoarthritic changes of the temporomandibular joint with flattening of the head of the mandible, sclerotic reaction of its articular surface, prominent osteophytic clipping of the head of the mandible as well as the articular eminence, and severe narrowing of the joint space. And sometimes the end result of the advanced degenerative changes of the joint is to reach the ankylosis of the joint, whether fibrous or bony. This is an example of bony ankylosis of the temporomandibular joint. You see the normal side with maintained joint space, and here you see flattening and sclerosis of the head of the mandible with total obliteration of the joint space, as you can see here. Then this is a sclerotic appearance of the mandibular condyle, and the articular disc is degenerated. You can see the abnormal signal of the disc itself, which is increased. The normal disc will appear black in all pulse sequences, and you cannot easily identify the posterior band of the disc. And here, this is in the closed mouth position, and you feel that the disc is displaced anteriorly, and here it may recaptured. Uh, uh, you can see that has been reduced to its normal position, but the disc is of abnormal signal. And this is advanced osteoarthritic changes by MRI. You see the narrowing of the joint space, flattening of the temporal eminence and the mandibular head, prominent osteophytic clipping of the articular surfaces. And this is also another example. Here you see marked narrowing of the joint space, and you see osteophytic clipping of the articular surfaces. You are not able to identify the disc, which is almost totally degenerated. And this is an example of a perforated or torn disc, where you see this is an advanced osteoarthritis of the temporomandibular joint. This is the disc which is uh, torn at its middle part, and there is narrowing of the joint space, bone sclerosis of the articular surfaces. And this is an example of disc perforation and osteoarthritis of the mild osteoarthritis of the temporomandibular joint. This arrow points to the site of perforation in the intermediate zone of the disc. This is the posterior band and this is the anterior band. And this arrowhead points to a small osteophyte in the mandibular head, and this means that there is some osteoarthritic change. And similar to any other joint, this joint can be the seat of synovial osteochondromatosis, which are multiple loose bodies within the joint capsule, and this will result from synovial metaplasia into cartilage, which will form multiple loose bodies within the joint space. This disease is very well known in the knee joint, in the hip, and in the elbow joints, but it can occur in any of the synovial joints, including the temporomandibular joint. And this is a good example where you see joint effusion and multiple loose bodies within the joint. Also, you can see in this joint synovial lipoma arborescens, and any of the synovial diseases like pigmented velonodular synovitis, and this joint can be affected by rheumatoid arthritis, and any other disease can occur in this joint, similar to those occurring in the rest of the joints all over the body. This was the informations about the temporomandibular joint. Thank you very much. Wassalamu alaikum wa